leishmaniasis, its control measures and indicators for tracking the progress. So the control measures mainly based on certain criteria like early diagnosis and complete treatment, integrated vector control management, including indoor residual spray, shortly called IRS, and effective disease surveillance, supervision, and monitoring and evaluation system, capacity building and program management, social mobilization, and partnership building at all levels, and finally the clinical and operational required research. So first we can discuss about the early diagnosis and complete treatment. Kala-azar services are integrated in the primary healthcare system. For early diagnosis, rapid diagnostic tests were introduced in 2005 and are available in all the implementation units in Kala-azar endemic states. They are procured with the domestic funds. So these diagnostic devices, diagnostic kits were purchased from the funds managed by the primary healthcare center and locally managed domestic funds. Community awarenesses leading to the increased health-seeking behavior. Community awareness is very important, that by creating community awareness only, we can increase the health-seeking behavior. And this is important mainstream of passive surveillance. Active methods are used for the early detection of Kala-azar and PKDL, including house-to-house searches, index-based searches, fever camps, and incentive-based approaches depending on local endemicity and stratification of disease transmission. I'm repeating, there are two methods, passive methods and active methods. Passive method is to create awareness in the society, by which we can create awareness about the leishmania. Another one is active methods, by which house-to-house searches, index-based searches, fever camps, and incentive-based approaches. And these are all will be determined based on the local endemicity and stratification of disease transmission. The treatment strategies for Kala-azar have evolved over time. This we can discuss in the 2-3 slides after. We can see in detail about the treatment strategies evolved, how it evolved over time. This starts from multiple painful injections of sodium stibogluconate and amphotericin B to very simple oral administration of meltofosine, and more recently to a single dose of infusion of liposomal amphotericin B. This is a very recent advancement in the treatment. Only one dose of liposomal amphotericin B is sufficient for the complete cure. Uninterrupted availability of drugs at the implementation units is another criteria that has to be maintained. The WHO has provided liposomal amphotericin B after 2014. This has improved the treatment compliance, and around 99% of cases, reported cases, gets complete treatment due to this availability of WHO free supply of liposomal amphotericin B in India. So these things we are discussing mainly about our problem, Indian problem, visceral leishmaniasis and its management issues. It is not applicable to the cutaneous leishmaniasis of Western countries. To improve the access and the availability of treatment, decentralized amphisome treatment centers have been established in 171 health facilities around the endemic area. So, due to this decentralized amphisome treatment centers, one can directly go and get the amphisome treatment, means liposomal amphotericin B. Its commercial name is Ambisome. So, this Ambisome treatment can easily be easily available for the people of endemic area through 171 health facilities. It has high acceptance ratio among the public because of reduced hospital stay. That means only 1 day stay is enough. And so 1 day stay gives very minimal wage loss. And the number of due to this, the number of new cases has fallen by 78% since 2014. So after starting this Ambisome treatment in 171 health facilities, the number of new cases fallen by 78% after 2014. Capsule meltofosine. Meltofosine is the oral drug which is available for treatment in the endemic area. Capsule meltofosine is the treatment of choice for PKDL because treatment to be taken for a prolonged period in PKDL. So the capsules, the drug which is available in capsule form will be more convenient for the patient. So the meltofosine capsules are supplied free of cost to the patients. Apart from this supply of drugs free of cost, to encourage treatment seeking and completion of treatment, a financial incentive of rupees 500 is given to each patient. No, sorry, 500 rupees is given to each person who is referring a new case. So the ASHAs, the self-help group is called ASHA. If anyone belongs to that ASHA group is reporting a new case, that person will get an incentive of rupees 500. The patient will get to compensate for loss of wages by Kala-azar patient and PKDL patient. The Indian government provides 4,000 Indian rupees per PKDL cases and 500 rupees per treated Kala-azar cases as incentive for the patients to encourage their treatment modalities, the treatment behavior. The government is giving these things free of cost. Apart from this, Indian government subsidy or incentives, the state government such as Bihar and Jharkhand, in which most Kala-azar and PKDL cases occur, provide an additional 6,600 rupees in compensation for wages loss to each Kala-azar cases. So these are all the early diagnosis and complete treatment. Next comes integrated vector control management, including indoor residual spray. So the first we discussed about the case management, case treatment, and its completion of treatment in human side. The second comes the vector side. So we have to tackle at every possible way to overcome this ever increasing disease. That is, second point is integrated vector management, shortly called IVM, and which includes indoor residual spray, shortly called IRS. For vector control or for the control of sandflies, 2 rounds of IRS are conducted in all endemic villages that have reported Kala-azar cases in the previous 3 years. So, say for example, if one case is the residual spray will be done for nearly 3 years. Because of the development of resistance to DDT, synthetic pyrethroids has been used for indole residual spray since 2015. Since 2015, every year, 35 to 38 million people at risk are covered in each indoor residual spray round. While the reported house coverage of indoor residual spray has been more than 80%, the assessed coverage has improved significantly from less than 50% in 2014 to more than 85% in 2019. So in this way, every year the coverage, the concern over this disease is increasing. During this period of 2014 to 2019, complete spray rooms, all the rooms plus cattle sheds increased from 35% in 2015 to 70% in 2019. So initially it was the coverage was very less, very poor, around 35% around 2015. But now the coverage has increased to 70%. As the Kala-azar vector commonly breeds in mud houses, concrete houses have been constructed in Kala-azar affected villages in various states and National Social Welfare Scheme under Swachh Bharat Mission, under Bharat Mantri Awas Yojana Gramin, to improve housing and sanitation of sanitations and environmental cleanliness. Then comes effective disease surveillance, supervision, monitoring, and evaluation. This is third important things to control, to manage the Kala-azar in India. To eliminate Kala-azar from India, the government of India has started a National Kala-azar Elimination Program in India. It was initiated in 2002. 2002 it was initiated. This National Kala-azar Elimination Program is now using a web-based online platform which is called Kala-azar Management Information System, shortly called KAMIS, since 2014. KAMIS contains electronic records of all Kala-azar and PKD cases since 2013 with the data on drugs, diagnostics, indoor residual spray monitoring, and vector surveillance. Data are entered in real time at the implementation level by trained data operators, and a mobile-based application of KAMIS is also available for field workers to monitor case deductions, indoor residual spray, patient follow-up, incentive distribution, etc. KAMIS is useful for monitoring at the desired level and providing epidemiological information. Apart from this KAMIS, a mobile-based application known as AmbiCal for calculating ambisome dosage is used in treatment centers. Routine field visits, periodic monitoring, and independent external assessments are an integral part of National Kala-azar Elimination Program to ensure conditions mid-course corrections. Then comes capacity building and program management. This capacity building and program management ensures the availability of trained, dedicated human resources as well as adequate funds for activities concerned with Kala-azar control and drugs and diagnostics and resource material available at each level. Engagement of stakeholders in program implementation and operational research or other activities under this category. Extensive operational research has been conducted by National Institutes of Excellence, the Indian Council of Medical Research, medical colleges, and international partners such as Speak Indian Consortium. This is nothing but setting the post-elimination agenda for Kala-azar in India. Liverpool School of Tropical Medicine and Rajendra Memorial Research Institute, Patna. Those institutes are working hand by hand to control to make this capacity building a successful one. And apart from this, social mobilization and partnership building at all levels. Any program will get success only after successful mobilization of public, means social mobilization. So the every part of the society has to be in the endemic area, has to be motivated for Kala-azar elimination, for taking proper treatment, for allowing the persons to use their houses for indoor residual spray, and partnership building at all levels are very important to get a successful success in the elimination program. Apart from all these, in-depth research is required in clinical and operational level. All sorts of improvement needs to be done. For that, the input of research is very much required. So much improvement has made in the treatment and in the control of Leishmania vector sand flies. Everything is now possible only because of the research so far done in clinical and operational research level in the control of leishmaniasis. Here, the photograph shows a person who is spraying indoor residual spray inside the houses and inside the house and the cattle sheds of in the endemic area. One can clearly see the nature of house there and the area of how people are living in the endemic areas. So this is the tracking the progress. So we have done so much. So how we have to track the progress? The letters are very small, so pardon me for this. So we have to track the progress of success and its issues related with the progress by means of various parameters. Number one is surveillance and organization of preventive and curative services. For this, number one is availability of guidelines, use of SOPs, standard information terminology and definitions in the program. So this is to avoid the confusions in the surveillance program, because a lot of surveillance program get less success, or sometimes the surveillance program gets failed due to lot of miscommunications. So that was avoided here in Kala-azar elimination program. And intensive case search activity. So we have to go for case search. We have to make a case search activity intensively to track the progress. Then only we can say whether our program is a success one or it is a failure one. So if the program to be a success one, we have to get less number of cases, even though if you are doing proper surveillance all over the affected area without missing any chance for cases. And third one is strengthen the information system to improve data collection, reporting, and data use for action plans. So this also to be strengthened, the data availability and data sharing system to be strengthened for the free flow of informations. and prevention of re-establishment of foci and emergence of new foci by environmental management. So we have to prevent the re-establishment of foci. Once after the elimination of infective foci, we should not allow the re-establishment of the foci again. So this can be achieved by proper implementation of the vector control management, proper spray activities, and giving proper replacement of mud houses, and giving proper instructions about the cattle sheds in the spread of Kala-azar. So by which we have to prevent the re-establishment of foci. At the same time, we have to prevent the appearance of new foci. It should not be like in one side we have to control the foci, in another side lot of new foci will develop. It should not be like that. We have to manage the whole thing such a way that the foci, the infective foci, should not re-establish, and at the same time new foci should not develop. Then outbreaks. We have to contain the outbreaks. At the time of making active implementation program and intervention strategies, the outbreak should not happen. Otherwise, if outbreaks, if it happens, then it indicates the failure of our program, the utmost failure of our program. Then diagnosis, case management, commodities availabilities, treatment and adverse drug reactions, these things to be monitored. So the time elapsed between onset of signs and symptoms and treatment to be observed, and diagnosis and treatment to be properly maintained, and relapses to be observed, because even after the treatment, people will think that they have been recovered from the leishmaniasis, but after some time, leishmaniasis will reappear in the treated patient. So those relapses to be avoided, because the relapsed cases will act as a source for fresh Kala-azar cases. Then Kala-azar during pregnancy also to be taken care of. And post-Kala-azar dermal leishmaniasis, picadial, these are all the source of simmering source of Kala-azar in many areas. And the next point is HIV visceral leishmaniasis co-infection. This to be given much attention, because HIV in HIV patient, visceral leishmaniasis is more severe, and the visceral leishmaniasis will not lessen. The drug will not generally cure the visceral leishmaniasis in HIV patients. So the HIV patient with the visceral leishmaniasis will act as a continuous source for the parasite. So if we are not taking care of this, then the patient, HIV-VL patient, will act as a source for parasite, and they will act as become the endemic foci for parasite. Then follow-up. So proper follow-up should be there. We have to that I have discussed in relapse also. So we have to do thorough follow-up up to complete treatment. So even after treatment, we should not leave the patients. And similarly, even in vector control management, we have to make thorough follow-up to avoid the reappearance of vectors in the endemic areas. And deaths should be properly recorded. There is nothing in hiding the deaths. So the proper record of deaths should be there to monitor the success of the program. And pharmacovigilance is also important, because a lot of side effects will come if the treatment is taken for a prolonged period. As I told previously, research is also an important area to update our knowledge in this field, because the fight between control and parasite leishmaniasis is continuously going on. So every time we are applying new method and parasite is getting adapted for that, and they are emerging as a super tolerant one. Research is very important to develop novel methods, newer methods to control emerging this disease, emerging leishmanial parasites. Next comes vector control. So the vector control to be properly followed, and the indoor residual spraying should be properly managed and monitored, and entomological surveillance properly done to measure the success of vector control. And patient and community participation is another important one. This thing we have already discussed in social involvement, and we have to encourage the society, people of the society, for the health seeking behavior. In the affected area, most of the people, even after getting the fever, they will not take proper treatment. They used to go to quacks, or they used to go to pharmacy to get temporary treatment, and then they will go for job, because this affects the Kala-azar affects the people of poor. This affects the poor people. They always give their attention only for the wages. So the health and their body and health are all a second priority, third priority to them. So this to be avoided by means of social involvement, making people knowledgeable about the disease, and we have to encourage them for proper health seeking behavior. So the community awareness and participation is also important, and any program will get success only after the involvement of society, involvement of community, and its participation. Stewardship and governance, I think this is not required, and budget, all those things, because NVBDCP is monitoring all those things, and NVBDCP is monitoring the Kala-azar elimination program, and they are planning, they are making programs, they are giving incentives, award schemes, everything managed by National Vector-Borne Disease Control Program, shortly called NVBDCP. And we have to get the budget allocation from the government for the successful running of this program, and to maintain, we have to also maintain the supply chain and stock management, proper supply chain and stock management, and also finally we have to maintain the best practice, best clinical practice we have to maintain to completely get rid of this deadly disease. This picture shows the vector control, how it interacts with the Kala-azar cases. Here the Kala-azar cases data given from 1977 to 2011. So here one can see here it follows a cyclic pattern. It goes up to a peak during some year, then it comes down, and again it goes to a peak and then comes down, and again it reaches a peak and then comes down. Generally it maintains a 10 to 5 year cycle. This is that we are generally calling it as cyclic occurrence of leishmaniasis. So whatever the strategies we are following, whatever the treatment procedure we are following, it goes down and then it comes up. It goes down and then it comes up. It maintains a cyclic pattern, 10 to 15 years of cyclic pattern. Here one can see the impact of DDT spray. Actually, it was originally planned for malaria control. Due to National Malaria Eradication Program, DDT was sprayed all over India. So during that program, DDT was sprayed in 1977. That was responsible for the case reduction in 1978, it has reached a peak. Then it started declining due to this DDT effect. But DDT persists on the land, not forever. So its efficacy, its effectiveness getting reduced over a period of nearly 7 to 8 years. So when the efficacy of DDT getting declined or decreased, so that place, the area will be established by the sunfly vectors. So once sunfly vectors established means then again there is an increase of cases. So in 1998, it has reached a peak of around 80,000 cases, nearly 80,000 cases. So government of India has launched a DDT spray this time, particularly for the elimination of Kala-azar, elimination of sunflies. So they have implemented for 3 years, from 1992 to 94. So after that, they stopped DDT spray. Once after stopping the DDT spray, the efficacy again declined in 7 years. So in correspondence to that, the number of cases declined slowly. Then after declined the efficacy of DDT, the cases again increased. So government of India started to spray statewide DDT spray in 2007. That led to a decrease of cases in 2008, 9, and 10. So this is the this pattern is determined by the spray of DDT in India. Here the same cases with the number of deaths given. The black colored line, one can see the number of deaths due to Kala-azar. So the cases in the previous slide, we have seen the increase and decrease of cases was linked with the DDT spray and vector control. But here, the increase and decreasing of death was related to the use of drugs. Here, SBV, the sodium antimony gluconate, in the first, during 1977, it was widely used. Sodium antimony gluconate during 1977. But the increased death in 1977 was due to a lot of drug, a pack of drug which was with some other ingredients, toxic ingredients. So that lot, wherever that lot was used, that was led to severe mortality. So that was the reason in 1977, lot of mortalities was observed. After that, in 1 year period, the efficacy of sodium antimony gluconate was declined. Because the sodium antimony gluconate was used for a long time, and the improper use of sodium antimony gluconate was led to the development of resistance, and the parasite was not at all listening to the sodium antimony gluconate. So after that, in 1979, the dose of drug, the dosage was increased. The dosage of sodium antimony gluconate was increased by WHO. And then the increased dose was lessening a bit. But after that, after some period, a parasite again developed resistance against that increased dosage. So WHO again in 1984 again increased the recommended dosage level. Then again it was lessening the cases, but that was also for a short period, for 2 to 3 years. Then again the parasite has developed resistance against sodium antimony gluconate. Then again WHO finally in 1990 increased the dosage, recommended dosage level to a level which was beyond that level will be very much toxic to the human itself. So the WHO stopped increasing the dosage further, and the sodium antimony gluconate lost its effectiveness over the parasite in 2020. In 2000 and in 2001, WHO recommended not to use this drug for the treatment. Then comes pentamidine. In 1983, pentamidine was also recommended as a drug of choice, as a secondary drug for the drug-resistant cases. But slowly, pentamidine also become less effective, and in the year 2003, WHO recommended not to use this pentamidine for Indian visceral leishmaniasis. Then in 1992, another drug has come, another wonder drug we can call it as amphotericin B, which is generally an antifungal drug, but which was found to be very effective for controlling visceral leishmaniasis. But only thing is this, the administration of this drug requires hospitalization, and this drug has to be administered as a infusion along with the saline solution or dextrose solution. It has to be administered as an infusion for long period. But this drug was very effective until 2011, until 2010. But after that, a very little resistance to this amphotericin B was reported. At the same time, in 2098 and 99, another drug, wonder drug, has come, that is called liposomal amphotericin B. It's a formulation of amphotericin B, which was 100% effective even till today, liposomal amphotericin B. Then in 2002, another drug, which is oral, which can be taken orally, was in practice from 2002. That is called meltefosine, oral drug. After meltefosine, in 2010, combined therapy was started. That was also still in practice. Thank you so much.